My name is Eddie Fan. I'm from the University of Toronto. It's my pleasure to moderate this session on COVID-19, what's the evidence in 2022. So like the previous session, we have 4 speakers. We'll have them speak and then have some questions and discussion at the end. So it's my pleasure to introduce my friend and colleague from the University of Toronto, Martin Erner, who's going to speak today about ECMO and ARDS for COVID-19, effective therapy or wishful thinking. Martin.
Hi, and thank you very much for allowing me to present work from our research group on the treatment effectiveness of ECMO in COVID-19. Our evidence for treatment effectiveness of ECMO therapy was so far based on the results of the EOLIA trial that investigated patients with ARDS of other etiologies than COVID-19. Early reports were very discouraging, mortality rates up to 90%, and even if you look at later analyses from the ELSA registry, some mortality rates range from 30 to 60%, and with mortality rates up to 60%, one might wonder whether we should actually treat COVID-19 patients with ECMO or not. In this project of the COVID-19 Critical Care Consortium, we were asking what is the effect on hospital mortality of treatment with ECMO if the PF ratio drops below 80 millimeters of mercury compared to conventional mechanical ventilation without ECMO in patients with COVID-19. We included all adult patients admitted to a participating ICU with COVID-19. ICUs participated from 30 countries across 5 continents, and our primary outcome was hospital mortality up to 60 days with the competing event of being discharged alive from hospital. You see on the left side the 2 treatment strategies we were comparing, and we emulated the pragmatic clinical trial using observational data with marginal structural models with inverse probability weighting, and we basically obtained adherence-adjusted estimates for the treatment effect of ECMO, similar to a per-protocol analysis of a randomized control trial. So how do you emulate a pragmatic clinical trial using observational data? In a regular randomized control trial, you would just randomize patients, basically a coin flip at the time point of ICU admission, and then assign to either the intervention or the control treatment strategy. In our registry data, we were not able to do that. So in order to provide exchangeability at baseline, we decided to clone patients, and then basically created for each patient a clone for each treatment strategy. So one clone of patient 1 was assigned to ECMO if the PF ratio dropped below 80 millimeters of mercury, while the other clone was assigned to conventional mechanical ventilation without the use of ECMO. This is statistically very efficient because patients contribute data to both treatment arms, but it also provides perfect exchangeability at baseline because clones are by definition identical at baseline. And then in a second step, we followed these patients over time. And you see here for patient number 2, the PF ratio on day 4 dropped below 80. And because the patient was placed on ECMO, the clone that was assigned to the ECMO treatment arm was perfectly adherent, and we continued to follow, but the clone that was assigned to the mechanical ventilation arm was non-adherent. It's basically a crossover. So we artificially censored the patient on day 4. And this artificial censoring introduces selection bias in an analysis because the censoring is associated with prognosis. So in the final analysis, we did a weighted analysis with inverse probability weighting, comparing what would have happened had all patients been treated with ECMO if the PF ratio dropped below 80, as compared to what would have happened if all patients had been treated with conventional mechanical ventilation without the use of ECMO, which corresponds to the causal effect of our intervention. The final analysis comprised 7,345 patients. At any time point during follow-up, 844 patients received ECMO therapy, and we found in the primary analysis that a treatment strategy which included ECMO if the PF ratio dropped below 80 millimeters of mercury reduced mortality of patients by 7.1%, corresponding to a risk ratio of 0.78 as compared to conventional mechanical ventilation. And the total effect of ECMO therapy, this is what you see on the lower panel, was partially mediated by ECMO therapy increasing the probability of patients being discharged alive from hospital. In secondary analyses, we investigated whether age or comorbidities acted as effect modifier for the treatment effectiveness. And you see in the upper area that the treatment effectiveness of ECMO therapy decreases with increasing age. Interestingly, different comorbidities like hypertension, obesity, and diabetes did not really influence the treatment effectiveness of ECMO therapy. However, these estimates have to be interpreted in the context of the baseline hazard that is very different for a comorbidity like obesity as compared to no comorbidities. We also measured how the preceding duration of mechanical ventilation influences effectiveness of ECMO therapy, and you see that over time, with increasing duration of mechanical ventilation, the risk ratio approaches the no effect line. Finally, we investigated whether we should use ECMO therapy to prevent exposure to potentially harmful intensities of mechanical ventilation as measured by static driving pressure. And we found a beneficial effect for such a treatment strategy, and the sweet spot, the threshold for initiating ECMO therapy seems to be around 15 centimeters of water, with more strict or more lax threshold being less effective. Altogether, in this registry-based cohort study, including 7,345 patients, we found that a treatment with ECMO, if the PF ratio drops below 80 millimeters of mercury, reduced hospital mortality by 7.1%. Risk ratio is in the same ballpark, in the same range as the results from the EORIA trial. And in secondary analyses, we found that patients benefit the most from ECMO therapy if they are younger, if they have more profound hypoxemic respiratory failure, if ECMO is used to prevent exposure to higher intensities of mechanical ventilation, and if ECMO is initiated early during the course of mechanical ventilation. Our findings are supported by other studies. These are two target trials that used a completely different statistical analysis approach. One is the study of Shahzad Chaefi with patients in the United States who found a very similar adjusted hazard ratio for mortality. The follow-up duration was also 60 days. And the other target trial is from David Hajjaj, who investigated patients in France, Switzerland, and Belgium, investigating 90-day mortality, and also found that patients benefit if they have more pronounced hypoxemic respiratory failure and if ECMO is initiated early. So the bottom line is ECMO is a highly effective therapy to treat patients with COVID-19, but only if the therapy is applied to very well-selected patients with more profound hypoxemic respiratory failure and early during the course of mechanical ventilation. I would like to thank Eddie Fan and John Fraser, Gianluigi Libassi, and all the members of the COVID-19 Critical Care Consortium. Without them, this study would have never been possible. Thank you so much.
Okay, thanks, Martin.
At the end.
Yep. So next, it's my pleasure to introduce David Furfurl, who's going to speak to us today about phenotypes in COVID-19 ARDS. What have we learned? So, David.
Thanks so much. This is my first ELSO, so very excited to be talking to you all. I also noticed some issues with the clicker, so I took out all my clever PowerPoint stuff, so get ready for some really boring slides. I have a couple disclosures, but nothing relevant to this talk. So in talking about COVID-19 ARDS and phenotyping, just to go back, why are we interested in this at all? We know that ARDS in general is a clinical syndrome with broad defining characteristics, and because of that, it inherently has quite a bit of heterogeneity from a variety of different factors, who the patients are, what's driving their illness, their comorbidities. I'd also argue that we're very familiar with phenotyping and using it to guide our therapy. So the most common is probably a clinical physiologic-based phenotyping based on disease severity that we already use regularly for prognostication and deciding about therapies like ECMO. But there are, of course, many other ways that we can break down this heterogeneity and phenotype our patients. And importantly, these clinical characteristics, we think, reflect a biological heterogeneity that we're trying to understand a little bit better so we can understand what drives the differences in our patients. And our goal is to go from a broad group of patients with one clinical syndrome that get a standardized set of care to these more phenotypically similar subcohorts where we can decide what therapies we should be using, their prognostication, and ultimately enroll them in trials differently and see if we can identify therapies that can help them. We think this heterogeneity has been a big obstacle to identifying especially pharmacologic therapies that are effective in ARDS. So what about COVID-19? In some ways, this should be an easier question. We've taken away one major source of heterogeneity. We know what's causing this, and it's the same respiratory viral ARDS, and it's caused by the same virus. But we all know that ended up not being that simple. So as the COVID-19 pandemic went on, we saw a variety of sources from comorbidities, age, severity, inflammatory, multisystem organ dysfunction, and eventually variants in vaccine status that drove different types of disease. And as you all probably remember, the first major question that came up was, are there unique respiratory phenotypes in COVID-19 ARDS? So this was a very big debate. I'm not going to go over all of the debate and opinions that happened, but more what we've learned since then in trying to define this a little bit. And so since in the last couple of years of studying COVID, many cohort studies have come out like this one, looking at a wide range of patients and looking at their respiratory dynamics. And what we see is that in terms of compliance and other respiratory physiology parameters, there's really a normal distribution. And this distribution does seem similar to ARDS from non-COVID-19 etiologies. The respiratory parameters matter. They end up correlating with survival, but we just don't see these big signals of two different types of diseases that are grouped into one. But even this characterization is pretty simplistic, and there have been studies that have come looking at more advanced methods. So in this larger cohort of 1,000 patients with 2 validation cohorts, latent class analysis was used. And to touch on that for a second, that's a clustering technique that's unbiased and agnostic to outcomes. So it's not like machine learning trying to predict what's going to happen, but more just looking for these groupings that exist within the data. And looking at these patients, they looked at the first 4 days of mechanical ventilation. They really saw no subphenotypes at any of the first 4 days when just looking at respiratory parameters like driving pressure, compliance, PEEP, ventilatory ratio. They did, however, maybe see some phenotypes emerge when they looked at changes over time. So these were the 2 phenotypes they ended up looking at when we progressed from day 0 to day 4, with the main distinguishing features being ventilatory ratio, dead space ventilation, and mechanical power. Now, there was no differences in outcomes in these groups in terms of mortality, ventilator-free days, but some differences in secondary outcomes like AKI, VTE, that we think may reflect the biology. So our takeaway from this is that there were not these 2 big respiratory phenotypes. There was likely a continuum of ARDS that we've seen before, but maybe there is something we can learn about looking at them longitudinally. So that's a segue into latent class analysis and how it's been used, or clustering techniques other than latent class analysis for ARDS not from COVID-19. And there's now a wealth of literature showing that when you apply these non-biased clustering techniques to ARDS patients, 2 phenotypes or classes seem to emerge that have been really referenced as hypoinflammatory or hyperinflammatory. And importantly, they have different outcomes and potentially different response to treatments when we look retrospectively at randomized data. So we partnered with Dr. Kafi and Dr. Sinha, who have done a bunch of those papers, to look at patients from the first wave of COVID-19. And we applied latent class analysis, but with a much broader range of characteristics than that last study. Respiratory mechanics, inflammatory markers, clinical criteria, multisystem organ dysfunction. And what we found is that 2 classes emerged like we've seen previously. On the bottom on the x-axis are the variables, and then we have their mean standardization. And you can see that one of the classes is characterized by higher levels of lactate, worse shock, worse multisystem organ dysfunction, and the other class is characterized by the reverse. The inflammatory markers go in the direction you would expect. In the middle, you see some factors that don't differentiate the classes, and you'll notice some things like compliance, PEEP, ventilatory ratio, P to F actually fall there, so they are not helping us distinguish these classes very well. The next question is, do these actually correlate with outcomes? Should we care about them? And they do quite a bit. So at 90-day mortality, and these findings go out to 180 days as well, we see a large difference between these two classes. Finally, we wanted to know, are these the same classes we're seeing in COVID-19 that we've seen in ARDS from other etiologies? So using a clinical classifier model that's been previously validated, we looked at these groups, and you can see that there is quite a bit of correlation between class 1 and our hypoinflammatory and class 2 and our hyperinflammatory. And we see that mortality difference bear out between the hyper and hypoinflammatory as well. Finally, the question comes, do they have different drivers, different biological heterogeneity that's influencing these outcomes? So we looked at two things specifically. The first was cycle threshold as a correlate for viral load. And we saw that patients in the whole cohort who had higher cycle thresholds, lower viral load, had lower mortality. But when we looked a little closer, this difference was only significant in the hypoinflammatory cohort. So the hypothesis could be that if you're hypoinflammatory, the more virus that you have, the worse your mortality. But if you enter into this hyperinflammatory phenotype, your viral load is mattering less at that time and not distinguishing your survival. This could end up influencing how you respond to different treatments. And with a huge caveat that this is retrospective, not randomized, but looking back at it, we do see some heterogeneity of treatment effect when we give steroids or look at what steroids patients received. So in the hyperinflammatory cohort, the patients who received steroids did quite a bit better in their mortality. But in the hypoinflammatory, there was no difference and actually maybe even a trend towards harm. And this statistical significance held up even adjusting for SOFA score and disease severity or illness severity. And we see the same thing in our COVID classes as well. So this could raise a question of doing treatments differently. You know, we have to have huge caveats of this, not ready for any prime time till we have long, big prospective studies. But there have been some small studies of people trying to look at this. So this was one out of Mayo Clinic with just 17 patients that received steroids, and they used a CRP-guided steroid strategy. And they did find that in that strategy, the patients received less steroids overall if it was triggered by CRP and had some more oxygen-free days with a trend towards no difference in hospital-free days. So in summary, we think that COVID-19 ARDS has similar respiratory characteristics to non-COVID-19 ARDS. There may be some changes over time that would be helpful for us to characterize patients. Latent class analysis reveals similar phenotypes as in non-COVID-19 ARDS, and they're associated with different drivers of the pathology potentially, but we need validation, prospective trials before any changes to clinical practice. And just thank you for everyone for the help and for having me talk.
Thanks, David. In a nice follow-up to this talk about phenotypes, our next talk is about cytokine storm, which also was making the headlines earlier in the pandemic. So it's my pleasure to introduce Dan Leisman from Boston, who's going to speak about cytokine storm in COVID-19.
Good morning, everyone. My name is Dan Leisman. I'm a third-year resident at MGH. I'd like to thank the conference organizers for inviting me to talk to you today about this very uncontroversial topic. I have no financial conflicts of interest to disclose, but I should disclose some academic conflicts of interest. This is something that I have a fairly strong opinion on and have voiced that publicly before. And so certainly there's always opportunity to introduce bias when someone starts with a hypothesis. So how did we get here? For me, a lot of this, I think, starts with this paper that came out in The Lancet very early on in the pandemic. This was one of the first observational cohorts that came out of Wuhan, looking at patients who were hospitalized with severe COVID-19. They found that relative to healthy controls, there was an elevation in multiple inflammatory markers, in particular interleukin-6, and they found that in patients who ultimately died of COVID-19, their interleukin-6 levels were higher. This has been corroborated numerous times. There are a number of studies that show that IL-6 is in fact a useful prognostic marker in COVID-19. And then this has been interpreted into what we have heard a lot about, this cytokine storm, by a number of, I will say, non-intensivists. This was a frustrating period for a lot of us who have ever run an ELISA for cytokine levels on a patient with sepsis or ARDS, because I'll point out to you the absolute values here of the IL-6 levels and note that they are quite low relative to what we see in hyperinflammatory syndromes of critical illness. So to show you this empirically, this was a systematic review and meta-analysis that we did earlier in the pandemic, where we looked at basically 1,200 patients with COVID-19, and we compared that to their cytokine levels to patients from large trials of sepsis, ARDS, and CAR-T-induced cytokine release syndrome. And just to get to the punchline here, so you can see that, yes, even in the critical COVID-19 group, those are patients intubated on mechanical ventilation, their IL-6 levels are quite high, but IL-6 levels are almost 100 times higher in cytokine release syndrome, 30 times higher in sepsis, and 12 times higher in ARDS overall. So let's get to some of the clinical trial data that is arguably the most support for cytokine storm theory. And so I think the biggest by far of these trials, right, has been the Recovery Dex trial. This was 4,000 patients who required supplemental oxygen and who had a CRP greater than 75. They were randomized to either tocilizumab or standard care, and the primary outcome was 28-day mortality, which was significantly lower if you received tocilizumab. And then there was a meta-analysis of all of the trials that were done at that point, basically showing a significant reduction in death if you received tocilizumab versus standard care. However, I may argue that some of this is slightly overinterpreted, and this is, the recovery trial is one of the most influential and important trials of our time. However, I will point out to you that in the tocilizumab arm specifically, almost 1 in 5 patients who were randomized to tocilizumab never actually got the allocated treatment. And presumably all of that is clinician driven, right? There's something about this patient that made the primary team unwilling to give the treatment as randomized. And so that's just one of the trials, right? We said that there's a meta-analysis that shows an overall benefit. But I'll again point out that recovery comprises 60% of all trials included, of all patients included in analyses of tocilizumab in a randomized fashion. When you add that with REMAP-CAP, which is again another open label adaptive platform trial, we're talking about 3/4 of all of the patients whose course has led us to this conclusion. Right, and so in contrast, if you look at the 3 largest placebo-controlled double-blinded studies, all 3 of those have a point estimate that is greater than 1. We're at ELSO, so we'll talk about ECMO, right? This is one small but randomized trial looking at cytokine absorption in patients with severe COVID-19 who were placed on VV ECMO and randomized to cytokine absorption versus no absorption. And so the primary outcome here was IL-6 level at 72 hours. But I will point out that 3/4 of the patients in the control group were still alive at day 30, compared to just 1 in 5 patients in the cytokine absorption group. Small trial, we don't want to overread this, but at the same time, that is certainly a safety signal that would give me pause. So if not cytokine storm, then what are we talking about here? And I think the answer is complicated, and we don't have time to get into this in a 10-minute talk. But so here are just a couple papers that I'd like to point out to you to highlight a few points, right? The host-pathogen interaction is immeasurably complex, right? And so there are a number of really elegant papers that have been done, like this one by Grant and colleagues in Nature, that shows this positive feed-forward loop between alveolar macrophages and T-cell activation, whereby interferon gamma is stimulated to be released by T cells, in turn activating macrophages and recruiting more monocytes and more T cells. It's a very elegant mechanism that has absolutely nothing to do with IL-6. Then there's the issue of whether or not things like cytokine blocking therapies work the way we think they do, right? And so this is another paper by Masoni et al. in JCI, where they found that IL-6 was able, in COVID patients, in BAL samples, stimulated a reduction in T cell and natural killer cell cytotoxicity, and that tocilizumab actually reversed the impaired ability of these cells to destroy infected cells within the alveolus. And so that raises questions about whether the effects of tocilizumab are driven purely by systemic inflammation reduction. We've already heard about the biological variability that exists between patients with COVID-19 despite the same insult, and so I'm not going to go through that again here. And I will point out this is another paper from Marcia Goldberg's group showing that there is a significant proportion of COVID-19 patients who are not just hypoinflammatory, but who have signatures of immunosuppression. And then this is another paper showing, this is from our group as well, showing that it's not just biological variability between patients, but that the same patient can vary in their inflammatory milieu considerably over time, right? And so looking here at the beginning of their course, ventilated patients have high levels of alveolar injury, as you can see in blue, with low levels of endothelial and cardiac and renal injury. And then over time, that signature very much changes where the alveolar injury is less of a factor, and we see more of this systemic endothelial injury and activation. So what I think this is really getting at is that cytokine storm factor fiction may not be the right question. And instead, I think there's a series of questions we should ask that may get us a little bit further and towards helping our patients. So first, is there evidence of inflammatory excess in COVID? I think yes. There's also evidence of immunosuppression. This is a contrast that is not unique to COVID. We see this in ARDS, we see this in sepsis, and this does not imply that cytokine excess is a driver of disease. More importantly, from a clinical perspective, does anti-cytokine therapy improve outcomes? I think maybe. I think there's significant limitations to the evidence we have, particularly around tocilizumab, and that the benefits of this therapy, if they are real, may be driven more by clearing infectious stimulus than by targeting inflammation, at least in some patients. Then there's the question of whether cytokine storm is a useful construct biologically. And here I will argue it is not. I think it oversimplifies a complex dysregulation of the immune system, and by focusing on cytokines specifically, I think that limits our understanding of how the host-pathogen interaction becomes maladaptive. And finally, and I will argue most importantly, is this a useful clinical construct to discuss cytokine storm? And I will again argue no, because I think it overlooks the extensive variability between the patients that we see and how these patients vary over time. Thanks very much.
Dan, I'm not sure if this is your phone. So last but not least, it's a pleasure to introduce Mela Bambia from Johns Hopkins. She's going to be talking to us about severe COVID in the pediatric population. So I look forward to your talk.
Hi, everyone. Thanks for hanging in there for the pediatric talk on severe COVID-19. Here are my disclosures. None of them is commercial. And I'll talk a little bit about the differences in diagnosis of multi-system inflammatory syndrome in children, or MISC, and acute COVID-19, as well as epidemiology of the two disease processes in children, and some ECMO characteristics and outcomes in children. The story of MISC started very early in the pandemic, with the first case series reported from the UK in March, April 2020. There were very few patients. However, the temporal relationship between the rise in cases of COVID-19 in the general UK population and the first cases of MISC that occurred about 4 weeks after SARS-CoV-2 exposure in children became recognized at the time. Several groups, including the World Health Organization, the Royal College of Pediatrics and Child Health in the UK, and the CDC here in the US, then developed case definitions for MISC. And cardiac involvement was recognized also relatively quickly. This is a report from the CDC conducted analyzing data from March 2020 to January 2021 that showed that adjusted risk ratios of myocarditis comparing patients with and without COVID-19 were over 30 in patients less than 16 years of age. And this was after adjusting for interaction between presence of COVID-19, sex and age group, race and ethnicity, payer type, hospital US Census region, and hospital urbanicity. For MISC in particular, Among 1,733 patients, also from a CDC report, 57% were male, 71% total were Hispanic and non-Hispanic Blacks. And among these hospitalized patients with MIS-C, 58% were admitted to the ICU, which we all felt as a huge burden during that time for our pediatric ICUs. The main driver for ICU admission was hypotension and shock. Cardiac dysfunction was reported in 31% of these patients, myocarditis in 17%, coronary artery dilatation or aneurysms in 16%, and pericardial effusion in 23%. The 0 to 4 years old age group fared the best with fewer complications, and the group of patients between 18 and 20 years of age had the highest rates of myocarditis, which was the main driver for ICU admission. In this separate cohort from the Overcoming COVID-19 Public Health Surveillance Registry that was also funded by the CDC, it was initially a little difficult as the pandemic progressed and patients with MIS-C appeared to have some very similar characteristics as patients with acute COVID-19, especially on the more severe spectrum. So in this cohort, those children between the ages of 6 to 12 years, those who were Black, non-Hispanic, and those who presented with primary cardiorespiratory or primary cardiac without respiratory organ involvement, and with a hyperinflammatory response on admission, were more likely to have MIS-C, whereas those with more comorbidities and those with extra cardiorespiratory organ involvement, including neurologic or GI organ involvement, were more likely to have acute COVID-19. And the rates of MIS-C and COVID-19 changed dramatically over time as we progressed through the pandemic, with most MIS-C cases towards the beginning of the pandemic and most acute COVID-19 cases requiring hospitalization towards the end of the pandemic. Here, the blue line are cases of MIS-C, but please note that on your left, the y-axis ends at 35 daily cases in the US, whereas the black dotted line represents daily COVID-19 cases, and the y-axis on your right-hand side ends at 800,000 cases daily. So just to put it into perspective. So how was ECMO used for this patient population? The ELSA registry COVID-19 dashboard includes currently 453 children with a median age of 11 years, somewhat older of a median of 14 within the ARDS subcohort. About half of them were male, and 69% were cannulated for primary respiratory indications, 25% for primary cardiac indication, and 6% for primary ECPR. And of note, in the ARDS subcohort, none were ECPR cases, at least in children. Overall mortality in hospital was 30%, and we'll talk a little more separately about the length of stay. So we heard yesterday about how important the denominator is, and I loved that one slide from Dr. Angus. This is another analysis of the Overcoming COVID-19 registry that was commissioned by the CDC, and it's currently under CDC clearance, so please don't share on social media or take photos until they approve this. But what I wanted to show here is that among 4,400 children admitted to 63 hospitals in 32 US states between March 2020 to December 2021, 2,700 approximately were admitted to the ICU. About 1,500 were MIS-C patients, and of these, 2.4% or 37 patients with MIS-C received ECMO. And about 1,200 had acute severe COVID-19, of which 5.9% or 71 children received ECMO. Again, just to put it into perspective of the type of care that these patients received over time during the pandemic. Patients with MIS-C who required ECMO support were significantly older than those with MIS-C without ECMO support. There were no differences in racial and ethnic group breakdown between patients with and without ECMO. But something that, and I apologize, I don't have a pointer, I didn't realize that. What's really important to note is that the vast majority of ECMO cases in the MIS-C population occurred in the pre-Delta variant period, and the vast majority, or 70% of the ECMO cases for acute COVID-19 receiving ECMO occurred during the Delta period. And that was a really tough few months for a lot of pediatric intensivists, right as things were slowing down on the adult side. Of those who were vaccine eligible towards the summer of 2021, when vaccines were becoming available in adolescents, and then for those 12 and above, and then finally in the fall for those 5 and above. So of those who were vaccine eligible, and were on ECMO support, required ECMO support, essentially all were either unvaccinated or with unknown vaccine status. And again, similar to what we've heard before, already on admission, patients who ended up on ECMO, and that's in order, this goes from non-ECMO acute COVID-19, ECMO acute COVID-19, and then in blue, non-ECMO MIS-C and ECMO MIS-C. So those patients who ended up on ECMO had significantly elevated ANCs, white blood cell counts, lactate, and creatinine the day of admission. Outcomes in this cohort, length of stay was significantly longer for both children with MIS-C and with COVID-19 who were supported on ECMO compared to their counterparts, which is to be expected. 27% of children with MIS-C on ECMO died prior to hospital discharge, and 37% of those with acute COVID-19 receiving ECMO died before hospital discharge. And discharge with neurological deficits were significantly higher in both patient populations, again, to be expected given severity of illness in these kids. And then lastly, among patients with acute COVID-19 receiving ECMO, 20% were discharged with new or increased oxygen support, 10% were discharged with new mechanical ventilation requirement, and 11% were discharged with new tracheostomy. But for what it's worth, these rates are actually similar, if not somewhat better, than historical cohorts of respiratory support for children on ECMO. And I had a couple of slides on therapies, but I hit them last minute to avoid going over time. So I think I'm right there, and we'll take questions. Thank you.
We'll ask all the speakers to come up and see if there are any questions from the audience. Sure, please.
Thank you so much. In the previous lecture, we discussed about the age more than 65 versus less than 65. During the pandemic, it was really ethically hard for us to decide if the patient is more than 65, just because the age we eliminate to get the ECMO. And as we see that hypoinflammatory response versus hyperinflammatory response. So in the future, if we have another pandemic or thing, I think we need a better selection. I know we had we didn't have enough ECMO to put on all our patients, and we didn't have enough ICU beds to take all those ECMO patients. But meantime, just eliminate patients more than 65, I think is not enough. to select?
Sure. Yeah, I think looking in that cohort, age was absolutely the highest predictor of mortality, and I agree with you that it hit very hard for people over a certain age. Interestingly, age does not distinguish between hypo and hyperinflammatory, so that is something to take into consideration even beyond the phenotyping of it. But I think for advanced therapies and things like ECMO, considering where the age cutoff is an important question.
Thank you.
Please, go ahead.
Okay. I had a question for Dr. Do I say Fafaro? I want to make sure I...
Yeah, Fafaro,
Okay.
that's right.
Yeah.
Dave is fine.
Way over here in the corner. So my name is Mike Mazzefi. I'm from University of Virginia. I wanted to ask you a little bit, you provided some nice data contrasting the hyperinflammatory, hypoinflammatory. What's the bedside practical best way to differentiate? So do you have a particular biomarker that's your go-to or a panel of biomarkers, or what do you recommend? And obviously there's a spectrum, so where's the cutoff in there to use your clinical judgment? How do you decide on that?
Yeah, that's a great question. I think that's sort of the key question, and I think importantly, we're probably not there yet to be using it clinically at the bedside. I think it's interesting to see if you can identify them prospectively, and there's been some work on this, and what people are looking for is a parsimonious distinguisher. In terms of biomarkers, the most common ones are using like IL-6, IL-8, things where we think we can get them available at hospitals, but they're also looking at just clinical classifiers. So that model that we use to distinguish these patients was just 10 characteristics that you have on most routine critical care patients, and the AUC for that was 94%. So it still needs to be validated that identifies them as well prospectively going forward, but some of the things like shock, acidosis, multi-system organ dysfunction do seem to have some value when taken all together.
Please.
Hey there, Wayne Strauss. I'm a clinician from Portland, Oregon. If I could ask two closely related clinical questions. One, what was your approach to the patients with like P to F 80 to 100 with maybe a negative clinical course where you're trying to balance utilization of ECMO versus waiting too long and the patient's no longer a good candidate? One, and then closely related, what was your thought about kind of non-data supported rescue therapies like APRV, neuromuscular blockers, pulmonary vasodilators that may improve P to F ratio, but we don't think improve mortality? Thank you.
Great questions. Martin, do you want
So in our BMJ paper, we investigated in a secondary analysis whether what's the treatment effectiveness for initiating ECMO therapy for PF ratios between 80 and 120 millimeters in mercury, and we still found that ECMO is more effective than conventional mechanical ventilation alone. These are secondary analyses and of course are hypothesis generating, but there might be some room. We also analyzed initiation of ECMO for patients with a PF ratio above 120 and did no longer found a mortality benefit. And in the final analysis, we placed all patients of the registry artificially on ECMO and compared to no ECMO. And if you do not well select the patients, mortality in the ECMO group is very, very high.
Yeah, I think also in the Stop COVID study by Shaifi and colleagues also found that higher PF ratios seem to benefit from ECMO therapy, so that seemed to be a relatively consistent signal. So it's interesting, something to investigate that perhaps, again, in ARDS, 80 is obviously the cutoff that was employed in Eolia, but maybe some milder diseases, and that might in part be some of the heterogeneity, right? So the PF is maybe a blunt instrument, but some of those patients have other phenotypic or underlying biological factors that are responsive to ECMO, but that needs further investigation. I don't know if any panel members want to weigh in on the second question, which I think is a good one, about other therapies like APRV, neuromuscular blockade, inhaled pulmonary vasodilators.
Yeah, I think a question with those therapies, any therapy that we know haven't shown clear data where we're having mortality benefit, I think always has a role depending on the patients, and we're tailoring our therapies. I think importantly, I just try to favor therapies that we know may have mortality benefit. So no one should ever not be prone because they're on pulmonary vasodilators and they don't meet criteria anymore. So as long as we sort of do it hierarchically and then are using it judiciously in patients, I think you could take that kind of approach.
Yeah, I think you know, in the maybe I don't know if the speakers might have better knowledge, but certainly in ARDS, non-COVID ARDS populations, PF ratios are poorly associated with outcomes. So you might recall that in the ARMA trial, the patients randomized to low tidal volume ventilation actually had worse oxygenation on day one, but eventually derived the 9% absolute risk reduction. So in routine practice, applying non-evidence-based therapies that improve oxygenation doesn't typically translate into a mortality benefit. So like this trials of inhaled nitric oxide, you know, as an example, or paralysis, really no, at the moment, convincing trials about the utility of APRV. So that's the thing. So in the it's just like the story of EV-ECMO. In the small population of severe ARDS patients, COVID or not, who are actually dying of hypoxemia, maybe using something to reverse that critical life-threatening hypoxemia makes sense, but that's a very small number of patients, right, who are actually dying of refractory hypoxemia. So happy to have an extended conversation about APRV. It's one of my pet peeves, but that's probably for another time. Any other questions? Please.
That's a general question that I know in the ARDS we focus on the 6 cc per kg for the tidal volume. When the patient is on an ECMO, after 2 days or 3 days, we usually wake the patient up and let the patient. At that moment, if the patient by himself has the tidal volume of more than 6 cc per kg, should we sedate, paralyze the patient? That was very in our facility. I'm from Montefiore, New York, so it was very controversial about that one. So I want to hear your suggestion. Thank you.
Sure. I don't know if anybody has any strong feelings.
It's a very good question, and I wish we would know the answer to that question. In the sense of how to titrate and guide respiratory efforts with regard to mortality outcomes or even longer outcomes, we are still working on that.
And I'll just add that, you know, growing data, we know that patient self-induced lung injury can be severe, just like ventilator-induced lung injury. I don't think we have perfect measurements of what it is yet, but balancing the harms of sedation and paralysis versus the harms of patient self-induced lung injury is something we should keep paying attention to for this.
In children, do you guys, when you wake patients up, do you also have some strict adherence to?
I was chuckling internally
Yeah.
because for the prior question too, we function in this gray area all the time because while your adult ARDS community has produced so much high quality data, a lot of those trials were not reproducible in children. Some because, you know, different groups have tried to reproduce them, and they were negative trials. And it's too long to go into the reasons that we think they were negative trials. And for some of them, large groups tried to reproduce them, but it's almost impossible to recruit enough patients to have an adequately powered study. So going back to the last question, it really, for us, it's very much an issue of balancing risks and benefits and basically taking it day by day and using our best clinical judgment. But we constantly function in that gray area. Children, because especially small children, they don't have a lot of muscle mass, so we see less of this phenomenon. We see it in adolescents who are adult size, but we see it much less in young infants, especially.
Great. Any other questions? Maybe I'll just ask Dan one question. So, you know, about the cytokine storms. It's just cytokines in general. Like, I think, unfortunately, it's part of the tale of critical care, right? We've been searching for magic bullets in ARDS, sepsis, like, over and over, and COVID seems no different. And cytokines always sort of enter the conversation, along with steroids. What do you think the future of looking for specific therapies targeting cytokines? I mean, it's a bit more general than COVID, but I mean, it just seems that every time we go looking, we're disappointed. Do you think there's a future for selective or targeted anti-cytokine therapy in critical illness?
If you have trouble intubating a patient, the first rule for the second attempt is to change something, right? I think we have, as you mentioned, we have 70 years of negative trials in sepsis and ARDS and critical illness looking at cytokine modulating therapy. I don't think that there are no patients who would benefit from that. But I think what needs to happen is, I think we're limited by our syndromic classification of disease in critical illness. And I think that overall, there are very few biological endotypes that we've identified that, right, where there is a underlying pathologic process that can be measured and that can be used to assign a disease state. And so I think it wouldn't be surprising if we enrolled patients trialing a treatment for acute MI, and we enrolled patients who presented with chest pain not otherwise specified, that we wouldn't see a benefit of these therapies. So I think the focus needs to be on identifying these biological subtypes, and then from there we can start to work on process-directed treatments.
Seems very sensible. Okay. Any other questions? If none, then we finish on time, actually a bit early. Please enjoy your lunch, and thank you to all the speakers, and enjoy the rest of the conference.